All right, so we can get started. Um, it's a wide topic, onco-nephrology, of course. It includes a lot of different subheadings, but then I will point out mainly the things which I've encountered in the clinical practice in the last few months after I started the onco-nephrology clinic, and this also includes, of course, what I see in the hospital. So I have no disclosures. Why this kidney cancer connection? Why such a growth in this area of nephrology? So we are seeing that there is a higher mortality in cancer patients with AKI or CKD as compared to patients without any renal issues. And most of these issues are getting increasingly complex, especially with the newer chemotherapies, newer the immunotherapy, stem cell transplant, and all of these were actually not part of our nephrology curriculum before. And really, to provide the best nephrology care for these patients, we need to understand the rapidly changing protocols and therapies. So this is just a broad view of onco-nephrology. Of course, this list is pretty long, but the main things that I will highlight is the AKI associated with malignancies, which also includes tumor lysis syndrome, electrolyte acid-based disorders. Believe it or not, I think I get more referrals for that than AKI or CKD in these patients. And then glomerular diseases in cancer patients, hematologic diseases, and then also, of course, we cannot forget how radiation associated, sometimes we can see post-obstruction renal disease. And then there are several other topics which I may not go into much details today, but at some point we should look into that too, such as pharmacokinetics of the chemotherapy in kidney disease and cancer screening in ESRD patients, ethics of dialysis initiation or withdrawal in these patients, and just in general palliative care in patients with kidney disease and cancer. So first, AKI associated with malignancies. In the last 2 decades, because of just improvement in the cancer treatments, there is improved survival of these patients. And because of that, we are seeing a rising incidence of AKI also, because the more chemotherapies or immunotherapies they're exposed to, the higher the risk of them having an AKI. The AKI may result from the cancer itself, like infiltration or obstruction, or the treatment of the cancer, like chemotherapy toxicity, or any associated complications like sepsis. So this picture kind of tells us what are the certain risks of AKI in these patients. Some can be iatrogenic risks, like chemotherapy-induced nephrotoxins, volume depletion, some disease-associated risks, such as post-renal obstruction, hypercalcemia. In the end, any type of kidney disease in these patients, it's going to have worse outcomes on their cancer treatment. They may get treatment ineligible, or they may need some dose reductions. And really, the doses have not even been studied that well in these patients. There may be a delay in their treatment. Many times we see when the patients develop a rise in creatinine, their chemotherapy is held, or they may have to be hospitalized. And then they may be excluded from certain clinical trials, again, because of limited evidence. Some of the cancer-specific risk factors for AKI are, of course, we know advanced age greater than 65 years, if they've had underlying congestive heart failure due to exposure to anthracyclines like doxorubicin or trastuzumab, which is commonly used in breast cancer, in any underlying CKD, volume depletion, patients with distant metastases, and then in patients with renal cell carcinoma, if they've had nephrectomy, that will definitely put them at a higher risk of AKI. As far as the pre-renal causes goes, there are several pre-renal causes, such as most of these patients have just decreased oral intake. They may have mucositis from the chemotherapy, nausea, vomiting, diarrhea, again as side effects or just as part of their cancer. And then third spacing because of severe hypoalbuminemia, we see that a lot. In post-stem cell transplant patients, they may develop skin graft versus host disease and have insensible loss of fluids from their skin lesions. And And again, the list can go on and on for pre-renal causes. But what I was looking into also, many of these patients, they probably had an underlying history of hypertension and they were diagnosed with cancer. They started the treatment, but nobody really looked at that they were also taking some medications which may have put them on at a higher risk of AKI. So that was one question that came to my mind. Do co-prescribed antihypertensives and diuretics increase their AKI risk? So these are some studies which have shown that the risk of AKI may increase in these patients who are probably already just continuing their ACE inhibitors, their diuretics, because they have high risk of volume depletion. So I thought in future that would be something which we can look into, is the benefit of preemptively stopping these medications in some of these patients, and even preemptive nephrology consultation, or even just maybe having them go to their PCP before they start chemotherapy to make sure that some of those medications can be stopped. Then moving on to the intrinsic renal causes, most common, as we all see, is ATN, which can be from several other reasons, like from chemotherapy, cisplatin, most common seen, any prolonged pre-renal condition, interstitial nephritis, crystal nephropathy from methotrexate most commonly, and then thrombotic microangiopathy from certain chemotherapies like gemcitabine, and myeloma-related kidney disease. Some post-renal causes can be bladder outlet obstruction from any GU malignancy, like from prostate, bladder, and any retroperitoneal disease, either metastases or fibrosis from prior radiation, or even widespread lymphadenopathy. Certain chemotherapies like cyclophosphamide can cause hemorrhagic cystitis, and then BK virus can also cause urethral strictures, and radiation therapy can also give strictures. Some of the chemotherapy agents that, again, based on what I'm seeing in clinical practice, I wanted to bring into discussion. Number one is cisplatin. It's one of the DNA alkylating agents, directly tubular toxic, and I wanted to just show how it causes the nephrotoxicity. So cisplatin enters from the circulation into the proximal tubular epithelial cell via the organic cation transporter 2 channel, causes an increased inflammation, increased TNF-alpha, P53 pathways, and eventually lead to renal tubular cell apoptosis and necrosis. So it's directly tubular toxic, can lead to salt wasting, hypomagnesemia. And one of the things that have been known from before is a low chloride environment enhances the toxicity. So usually this already is something oncologists do, is give them a lot of normal saline with the infusion. 1/3 of the patients can still develop AKI, and it worsens with repeated dosing. The tubular injury can be permanent with doses greater than 100 milligram per meter square. Other platin agents like carboplatin, oxaliplatin are known to be less nephrotoxic, but still we do see a lot of electrolyte abnormalities. Some of the risk factors of higher cisplatin toxicity is female sex, low albumin state, hypomagnesemia. And that is something I wanted to point out today, which is something being looked into for future research or even just practice improvement. So for prevention and treatment of cisplatin nephrotoxicity, primarily supportive discontinuation of cisplatin, volume repletion, but then magnesium supplementation is something which is being studied that can probably reduce risk of cisplatin nephrotoxicity. The dose that to be given is about 8 to 16 milliequivalents. These are a couple of studies which have been done to show that when there is only crystalloid regimen given before cisplatin, there is a higher change in creatinine, whereas if patients are given magnesium supplemented regimen, there is a lower change of creatinine in these patients. So again, something to look into future to give magnesium to prevent cisplatin nephrotoxicity. Now, this is something which is being looked into more in the basic science world, not yet in clinical practice, is SGLT2 inhibitors can also be given for reducing risk of cisplatin nephropathy. This study was done in mice. They used canagliflozin, which significantly reduced the risk of cisplatin nephrotoxicity. The mechanism was that it inhibited that P53 pathway, which I was showing you here, and therefore did not cause the proximal tubular cell apoptosis. So again, something to look into for future clinical practice. The second chemotherapy agent, ifosfamide, which is mainly used for GU malignancies, can cause AKI in up to 30% of patients. Primarily also causes proximal tubular injury, kind of similar to the cisplatin pathway. So enters from the circulation into the proximal tubular cell through the OCT2 channel, metabolizes into chloroacetaldehyde, which leads to proximal tubulopathy. Also has a byproduct aldophosphamide, which eventually leads to bladder irritation and hemorrhagic cystitis. Another characteristic which it causes electrolyte and acid-base abnormalities, Fanconi syndrome, in which you can see glucosuria with a normal serum glucose, hypokalemia, hypophosphatemia, proximal renal tubular acidosis. Again, cumulative dose of more than 100 gram per meter square causes severe tubular injury. And the risk factors are if these patients have prior cisplatin therapy, since it is used in more GU malignancies, any tumor infiltration of the kidney also is a higher risk factor, and underlying CKD, of course. And then the third drug, which is methotrexate, and this is something we see more in the inpatient side. Patients are given IV methotrexate, high dose, more than 1 gram per meter square. And it can be nephrotoxic by causing intratubular crystallization and obstruction. And these are the methotrexate crystals that you can see in the urine sediment. One of the characteristics of methotrexate toxicity is it causes a non-oliguric AKI and a rapid rise in serum creatinine. So the urine output may be well preserved, but you will see a rapid rise in the serum creatinine. Again, something which is already being done, but still can cause toxicity, is urine alkalinization. So patients, when they're admitted to get methotrexate, they're already receiving bicarbonate infusion to keep their urine pH at least 8 to 8.5. And that is believed to prevent precipitation of methotrexate crystals. The other complication is once there is an AKI, methotrexate can accumulate and cause neutropenia, hepatitis, mucositis, and even neurologic impairment. One question we have been asked is, can we dialyze it off? Yes, dialysis can acutely clear the methotrexate, which is in the blood, but then it is highly albumin bound. So there is a higher rebound of the methotrexate levels after discontinuation. Another agent I was looking at, but I don't think we have it available, is carboxypeptidase G2, which can rapidly convert methotrexate to an inactive metabolite. But again, that also means we are completely then reversing the effect of this chemotherapy on the patients with cancer. Then after the chemotherapy, let's move on to the targeted therapy. Targeted therapy, what they mean is basically the drugs that are acting against the VEGF pathway, vascular endothelial growth factor. So these are the anti-angiogenesis agents. One of them is the monoclonal antibody to VEGF, such as bevacizumab, and then tyrosine kinase inhibitors of the VEGF pathway, like sunitinib, sorafenib, exitinib. These are usually associated with podocytopathy, hypertension, proteinuria, rarely can also, because of the same mechanism, can cause TMA. One good thing is these complications can resolve once the drug has been discontinued. So important to identify early on. This is just to show how in the last 2 decades, so many anti-VEGF agents have been found and being used for the cancer treatment. Then moving on to immunotherapy or immune checkpoint inhibitors, which I think was a great evolution in the oncology world and has been very effective for so many of the cancers, most importantly, metastatic melanoma. Having said that, it is a double-edged sword, causes a lot of immune-related adverse events. Kidney-specific directly causes acute interstitial nephritis, acute tubular injury, or even some glomerular diseases. Indirectly, patients can develop immune-mediated colitis, severe diarrhea. One question which is being asked is, do we actually biopsy these patients to prove if this was an immunotherapy-related adverse event? I think if they don't have any other immune-related event, then we should. But let's say if they also have something like maybe skin condition or immune-mediated colitis, and they are anyways going to be treated with steroids, maybe then may not have to take the risk of biopsy. But it's important to biopsy because then the treatment is to give them steroids, and that's really just completely reversing the effect of the immune checkpoint inhibitor. Then moving on to hematopoietic cell transplant. This is also something we are seeing a lot, especially at University Hospital because of the bone marrow transplant unit. Over the last 3 decades, the number of transplants have dramatically increased, and the technique is so much better now that even older patients with higher comorbidities are being transplanted. All patients, regardless of the type of transplant, are really susceptible to having infections in the first few days after the transplant until the engraftment is complete. And that is the time when they are at most risk of developing AKI from ATN in the setting of sepsis. Some of these patients may also be on calcineurin inhibitors to prevent graft versus host disease, so that further increases the risk. These studies have shown that if the patients need renal replacement therapy after the stem cell transplant, their mortality goes higher than 70%. And actually, when I think before when Dr. C was here, he used to have this regimen. As soon as they get transplant, he used to give them a lot of fluids just so that he can mitigate the risk of the AKI. Again, that has its own adverse effects, but it's really, really important to keep them away from developing an AKI. So that's within a few days itself. And then that's before the engraftment is complete. Once the engraftment is set in place, then patients can develop engraftment syndrome, which is within days after an autologous stem cell transplant. And what that means is there is basically an immense cytokine release in association with rapid neutrophil recovery after the stem cell transplant. And patients can develop fever, pulmonary edema, severe skin rash, and peripheral edema. These patients have a little bit of a better prognosis in terms of they recover renal function if you give them corticosteroids. And then this is one of the complications of stem cell transplant, which has 100% mortality. It's rare, but again, if happens, that can be really catastrophic. And that's called hepatic sinusoidal obstruction syndrome. This is within the first month after the transplant that patients can develop AKI. In this, what happens is before the transplant, the pre-transplant conditioning regimen that is given, such as melphalan, that can induce sloughing of the endothelium of the hepatic sinusoids and eventually lead to fibrosis and obstruction and lead to liver failure. And these patients can mainly develop hepatorenal syndrome, and that's why it is has pretty much 100% mortality. And then lastly, I want to point out on the transplant-associated thrombotic microangiopathy. And again, it's about 2 to 20% kind of variable, which can occur in these patients and present with progressive AKI, anemia out of proportion, hypertension. Risk factors for this is if patients have acute GVHD, recipient donor mismatch, or an underlying adenovirus infection. Important thing to note, these patients don't have ADAMTS13 deficiency. So even though we have been asked, they're not responsive to plasmapheresis. So really there's no benefit of, in fact, maybe harmful. Calcineurin inhibitors are also, as we all know, associated with TMA. So important if they're on this, if they can be withheld or reduced in dose. So now that we talked about all the AKIs, let's move on to the electrolyte abnormalities. And these are some of the cases that I saw, which I would like to discuss. Case number 1 is 58-year-old female with newly diagnosed breast cancer, triple negative. She was treated with Taxol, carboplatin, and pembrolizumab. After about 6 weeks, she has she's noted to have a sodium of 121, complaining of nausea, vomiting, got admitted in the hospital because of severe hyponatremia, has had overall poor PO intake, but still drinking good amount of fluids, has noticed some leg swelling. Vitals wise seems like pretty stable. Physical exam only positive finding was edema. She was not on any other medications other than the cancer treatment. Her labs, so when she gets admitted, her repeat sodium is 123. Her serum albumin is very low, 2.1. Urine osmolarity is higher, and urine sodium looks like is also greater than 40. The causes of hyponatremia in cancer patients, several causes, and not very different from what we see in non-cancer patients, but certain things are more specific. Of course, need to make sure there's not pseudo-hyponatremia because of paraproteinemias in more hematologic malignancies. And then if they have any underlying CKD or AKI, they will have reduced water excretion, so they may have hyponatremia from that. Other than that, one of the commoner ones that I think we may not even be consulted for on them is just hypovolemic hyponatremia, just overall decreased circulatory volume because of nausea, poor oral intake, and they usually, improve with IV fluids. I think the one that we face the most challenge in treating them is the one with total effective circulatory volume being decreased because of severe hypoalbuminemia or maybe with liver metastasis, which may basically be prototyping like a hepatorenal syndrome patient or like cardiorenal syndrome patients. SIADH, just in general, the most common cause of hyponatremia, maybe because of tumor release of ADH itself, especially in small cell lung cancer. Again, those are the ones, so far in my experience, are the most difficult to treat. And then from head and neck cancers too. These patients also have a non-osmotic stimulus for ADH, like pain, nausea, vomiting pretty much all the time. And then cisplatin can cause salt wasting. As far as evaluation goes, again, nothing different from our other patients. They may be asymptomatic if mild case, headache, fatigue, metastatus changes if severe hyponatremia. Exam-wise, make sure they're not orthostatic hypotensive to see for any volume depletion, and then edema, especially in patients with third spacing states. Urine sodium, if less than 20, of course, they are in sodium avid state, but that can be just in pure hypovolemic hyponatremia, but also in severe hypoalbuminemia, we can see low urine sodium. And then urine sodium higher, suggesting more euvolemic states, such as in SIADH or even in salt wasting. Moving on to treatment options, and this is going to be the main focus. Fluid restriction, we know, is the mainstay of treatment, but again, extremely hard for these patients, especially in the outpatient setting. Um, so we tend to resort to salt tablets concurrently with loop diuretics like furosemide. In hospitalized patients, especially the case that I just talked about, sometimes we do give them 25% albumin with a loop diuretic to try to get their sodium up to at least above 125, and then they can be stabilized on a salt tablet. Dimeclocycline also you can use, and if everything fails, then you can use tolvaptan, V2 receptor antagonist, but then again, limited by expense, hepatotoxicity. Expense, I would say, is the most challenging part, where getting insurance to cover it. Vaptans, as we all know, block the V2 receptor, keep the aquaporin 2 channels open, and therefore dilute the urine, increase water clearance. As I was telling earlier, small cell lung cancer patients having high ADH release, very, very difficult to treat. Dr. Ward is probably familiar with one of the cases we had, but really refractory hyponatremia failed all treatment options for the patient that we had, including dimeclocycline, high-dose salt tablets, everything. And we basically had to keep the patient out of the hospital so that he could get chemotherapy so that the lung cancer could be treated and eventually not have the high ADH. And we ended up having to give tolvaptan, and the patient is still on it, but the problem is getting the drug from the insurance company, very expensive. So that is one of the challenges. And then there is when patients have, let's say, overall just poor osmotic intake, poor oral, like poor solute intake, then you can also give them urea, because salt tablets are really not very pleasant to take. So urea, again, we don't have it available in the hospital formulary, but can be given as an outpatient. It's like a basically health food supplement. Two brands that so far I'm familiar with are available is Urina, lime flavored, and then Uriate. This is like 15 grams packet. I think 8 packets cost somewhere around $90 to $100, but insurance doesn't cover it. I think if they have FSA funds or something, it can be paid through that. Important thing to note is osmotic load that can be given with 1 packet of urea is equal to 7.5 grams salt tablets. So that's great, because have patients to take 7 or 8 salt tablets is really, really challenging, especially the cancer patients. So some success there that we have noticed, but again, getting the expense is the problem. Okay, so then moving on to other electrolyte abnormalities, and this case would cover both hypokalemia and hypomagnesemia. We have a 52-year-old female with endometrial carcinoma who is being treated with Taxol and carboplatin, has serum potassium of 2.8, persistently low despite aggressive repletion, and magnesium persistently below 1.5. So hypokalemia causes in these patients, the more obvious ones, decreased appetite, vomiting, diarrhea, but also not to forget chemotherapy-related renal potassium wasting. And this can be persistent for months to years, even after the treatment has been stopped. Requires aggressive replacement, difficult with oral intake, some IV dosing. Many times you have to just give them IV, and they get it usually in the infusion center itself. Important thing to note is hypokalemia is going to be difficult to be treated if their magnesium is not replaced. So important to always make sure that the magnesium has been corrected as well. And the relation between the two comes from the collecting duct principal cell, where if the intracellular magnesium is low, it's going to keep the ROMK open, high efflux, and high potassium wasting. So therefore, important to have their magnesium repleted. So that brings me to the hypomagnesemia evaluation and treatment. Of course, history, diarrhea is one of the more common causes. But then exposure to some of the chemotherapy agents, especially platinum drugs, which cause mag wasting. How to check for that? Try to hold off on giving the IV magnesium unless they are having a cardiac arrhythmia. Check for fractional excretion of magnesium. If greater than 15%, that suggests more renal wasting. 24-hour urine magnesium, we have ordered multiple times, does not work. It's a send out test. They need a special agent to collect it, which most of the times is not communicated from the lab to the nurses. Renal mag wasting can subside after some time in case of the VEGF antagonist, but platinum drugs, renal mag wasting can last up to even 6 years or even can be permanent after stopping their chemotherapy. And hypomagnesemia, I would say, is the one which I'm seeing more in outpatient referral. Many patients come in asymptomatic and less than 1.5. So management, stop the offending agent, but can't really stop the chemotherapy. Replace oral, IV, and I'll explain the caveats to all of these. IM, but then they are thrombocytopenic and have severe complications. I had one patient who developed buttock hematoma and needed debridement and whatnot because of IM magnesium injections. Then other novel approaches are subcutaneous magnesium pump and SGLT2 inhibitors. And then amiloride, as we know, the potassium sparing diuretic, can also be given, but it's an off-label use. So oral magnesium replacement, magnesium oxide, higher diarrhea, so it's kind of like a vicious cycle. Is it really repleting their magnesium stores? So one of the slow mag or magnesium chloride is the one which is slowly absorbed, causes less diarrhea, better tolerated. So you can give that, or magnesium lactate is another sustained release form. There is a protein drink used in pediatric patients, but I found that it's really over the counter and patients can get this as well, is magnesium protein complex, which has about 26 milligram of soy protein in it. So it's kind of a double win situation. So IV magnesium has its own caveats. Yes, can be used to replete in the acute setting if somebody is having an arrhythmia from hypomagnesemia. But really these patients, because they are chronically hypomagnesemic, not sure how much IV magnesium is going to really help, because anytime there is an abrupt increase in serum magnesium levels, it eventually inhibits the stimulus for mag reabsorption. Therefore, it causes actually more magnesium wasting through the kidneys. Amiloride, again, as I said, off-label use. It's an ENaC blocker, reduces sodium influx, decreases the electrogenic exchange of proton, potassium, magnesium. Has been mainly used in mice, but clinically, actually, we are using it, and I've seen they need at least 10 milligram dose for their fractional excretion of magnesium to go below 10%. So that is, amiloride can be used. But again, have to keep in mind risk of hypotension and volume depletion from that. And this is some of the future research or which is being currently looked into, off-label use of a subcutaneous MAG pump. This is basically like an insulin pump actually. MAG sulfate 4 grams in 100 cc normal saline is mixed and put in the pump, which can be infused over 10 to 12 hours. And patients basically just wear it. And then SGLT2 inhibitors are also considered to be MAG sparing. Hematologic disorders, so multiple myeloma, again, very wide topic, but one question which has been raised multiple times I wanted to address through this case. We have a 37-year-old male with nosebleeds, showing anemia, thrombocytopenia, renal failure, creatinine of up to 8. Workup showed IgG lambda multiple myeloma. Light chain burden-free lambda light chain is about 1,300, and we are consulted, interestingly, not for the AKI, but to do plasmapheresis. So before I move on to that, monoclonal gammopathies have multiple kidney manifestations. Most common one, as we see, is the cast nephropathy, then light chain deposition disease, AL amyloidosis, cryoglobulinemia. And then more newer entities is proliferative GN with monoclonal immunoglobulin deposits, or PGN-MID. Regardless, treatment is, the key is rapid reduction in the free light chains. And earlier we can reduce the free light chains, higher is the rate of renal recovery. Dr. Long has really studied this in severe AKI due to cast nephropathy. If the free light chains are reduced by 60% in the first 21 days, there can be 80% of renal recovery in these patients. Patients can come off dialysis as well. So that's where I think the key is actually to give them the bortezomib-based chemotherapy, or CyBOR-D, which is cyclophosphamide, bortezomib, and dexamethasone. Bortezomib has shown to rapidly lower the free light chain concentration within the first week itself, and that's what has led to significant improvement in the renal dysfunction. And the great thing is there is no dose adjustment needed for renal function with bortezomib. And this was the main question, the extracorporeal removal of the free light chains. Why the interest has been developed in this is because these light chains are smaller molecular weight, 22.5 kilodaltons for the kappa and 45 kilodaltons for the lambda. And there were several smaller trials which were done initially that suggested plasma exchange can effectively lower the free light chain concentration and have improvement in the renal function. But these were all small, single center and underpowered studies. Largest randomized control trial, which was this one, of plasma exchange did not demonstrate any benefit in these patients actually. And I think the reason for that is because free light chains have a large volume of distribution. 85% of these are confined to an extravascular space. Therefore, a 2 hour of plasma exchange session sure can initially reduce your free light chain levels, but there is again going to be a rebound effect. If you check daily free light chain levels in these patients, it's going to rebound every time you check them. And also these trials were all performed before the availability of bortezomib containing regimen. I think one of the things that should be looked into, maybe doing both concurrently, like start the chemotherapy and also do an extracorporeal removal to see if that's more effective. But since just with chemotherapy itself, we are seeing such great benefits, I don't know if there's any benefit of the extracorporeal treatment. So, and then high cutoff hemodialysis because of larger pore size of the filters has also been looked into, but we don't have it readily available here. Glomerular diseases, very briefly, just some of the important ones. VEGF inhibitors, as I mentioned, cause podocytopathy and also renal limited thrombotic microangiopathy. But a good thing is they resolve once the treatment is stopped. Okay, so we have another case, 60-year-old white woman who comes in for evaluation of nephrotic range proteinuria. She's had 1 month history of worsening lower extremity edema. She has history of malignant melanoma, was recently treated with ipilimumab, which is one of the immunotherapy agents after she failed the chemotherapy. Her melanoma has responded well, but now she has this 8.5 grams of proteinuria and nephrotic syndrome. So this patient actually had one of the, again, not many cases have been reported. It's ipilimumab-induced lupus-like nephritis. So yes, they can cause acute interstitial nephritis and tubular injury, but can also cause these glomerular diseases. It's one of the CTLA-4 antigen monoclonal antibody used mainly for melanoma and has shown to cause this lupus nephritis-like picture on renal biopsy. It's important not to miss any new onset hypertension or edema, proteinuria in these patients who have been given chemo or immunotherapy. Then pharmacokinetics, mainly bisphosphonates is the one that I would like to point out because we get asked a lot about that too. Zoledronic acid and pemetronate. Both are nephrotoxic, causes ATN or collapsing glomerulopathy. Frequent dosing is what leads to higher risk of nephrotoxicity. And once that GFR is below 30, then we should avoid using any of these bisphosphonates. If patients have hypercalcemia, usually recommend denosumab. And they should not be given doses more than every 3 to 4 weeks. Before each dose, check creatinine. And if there is a rise in creatinine more than 0.5 in somebody with normal renal function, then dose should be held. Or if more than 1 in somebody with abnormal renal function at baseline, also dose should be held. And then cisplatin, we pretty much talked about. Cisplatin with dialysis, again, is highly irreversibly protein bound. So for patients who are on dialysis, initial dose should be reduced by 50% because if they develop cisplatin toxicity, then we cannot really dialyze it out because it's highly protein bound. And then last topic, the palliative care. I think this is also important to know that the pain medications used in these patients avoid morphine, codeine, can use hydromorphone, fentanyl, gabapentin, but with cautious dosing, and then use with caution tramadol, hydrocodone, oxycodone. And then this is one of the points that any patients with CKD or ESRD and cancer have 30% lesser survival than just cancer patients alone. So only 40% survival, 5-year survival rate in them as compared to just cancer patients, which is 66%. Thank you. I hope I have not a lot.
That was really good. There was some talk about whether
Yes.
does it seem like that sometimes we all want the creatinine to.
Yes, so, and this was something I might have learned in the last few months. Some centers are doing, like they're restarting along with like a low dose prednisone, like they keep them on 10 milligram daily prednisone and continue, restart the immunotherapy. So while monitoring the creatinine closely. So I think.
Y'all done that?
No, I have not.
But
that's probably, I think, the timeline so far.
Yeah.
I mean,
I just think it's
right. I think the other thing which I have noticed so far is patients, and I don't blame them. For them, their cancer is the biggest priority. They don't really realize what a creatinine of 2 to 4 to 5 means. They just come to us for the evaluation, but then they're like, oh, no, you're telling me to stop my chemotherapy? No, I'm not going to do that. So that's also one of the challenges, I think.
Hey, can you hear us if we have a response?
Yes.
Can you hear me?
Yes.
Yeah, so yeah, I don't know if you touched on that. So you talked about the metastatic melanoma. I've seen cases where anti-TNF also has caused lupus like, LN.
That is correct. Yes, I think that has been reported as well. Hmm.
And for the transplantation, better if they have cellular. At least you give them steroids. But if they have antibody,
I used to think if just giving steroids means, or that's what we were taught in fellowship was, that means that's it. You cannot give them checkpoint inhibitors. But this is more recent, what they're giving both concurrently,
Yeah.
like a low dose steroid and checkpoint inhibitor.
even with the gotten the checkpoint, usually cellular.
Mm.
So we do it with
Wow.
steroids. That's why the antibody therapy, so they
Mm. Right.
Dr.
As you
Garg, can
said,
you can you repeat the discussion? Because we're not hearing, I hear bits and pieces of
oh,
discussion. Just to,
yeah. So Dr. V had pointed out that how in post-transplant patients, if they get on immune checkpoint inhibitors, they almost always see rejection in them. And then Dr. Yusuf said that, if, at least if it's T-cell mediated rejection, you can treat them with steroids. But mostly they end up losing the kidney and end up on dialysis. And then I was going to say, it's important to save the patient at some point and the kidney, as we were discussing earlier.
But you'd be surprised.
Yeah, that becomes, that's
Yeah,
true.
they have a hard
Mhm.
time.
Right.
One side. Okay. We're good. The attending they will treat getting a chance. Has it changed? Are you a good person to navigate behind the scenes and maybe because I mean
Yeah.
I think this is really an issue for our patients.
What Dr. Ward was asking was in cast nephropathy patients, at least at UofL Hospital, inpatient, they're not giving Cybo-D and asking us to do plasma exchange and then kind of do chemotherapy as outpatient. And the practice, unfortunately, as you just mentioned about the most recent case, has not changed. But I think this is the time where we need to start educating ourselves and them about how, and also the bortezomib, at least they can give bortezomib and dexamethasone. Cyclophosphamide, understandably, is the one I think that they hesitate to give in patient or in patients with renal failure. It does not need dose adjustment. So we should try to, I wouldn't say argue, but more, exactly say, yeah, that, just doing plasma exchange is of really no benefit.
Is it mostly because they want to give the therapy outpatient
Mhm.
rather than initiate?
And that's actually not just for myeloma treatment. For any other oncology treatments, pharmacists say that they just want to do it as outpatient. Exactly, insurance, because otherwise hospital end up. And this is, I think, and Dr. Castor might know this also, that in GN patients, same problem with giving them rituximab. Hospital does not, we have to really fight for it because then hospital has to pay for it.
yeah, I mean, we've had that with ANCA-vasculitis patients, and
Yeah.
I've been really hesitant to allow them to wait till outpatient unless it's within a week. Obviously, we start with the high-dose steroids, but the patient comes first.
Yeah.
Typical pleasant freezes primarily for adult, but we do have excess. Some people have done permutation, long treatment, for volume, large VD, that might be a look at. Probably.
Yeah. And how long do they, like, is it something the nurse actually does it like sits with the patient for long treatments? Okay,
No, you can't do it.
right.
So any evidence?
The comment was that the short treatments couldn't address because they weren't being alternative ways to approach that.
Yeah, we can look up, right, the volume of this, yeah.
That's not what it changed.
And the other thing I think is also production. The plasma cells are just producing these light chains so rapidly that even if you clear that, yeah, unless they give chemotherapy concurrently, maybe that's where. Right, no.
Addressing the short.
Yeah. All right. Great, thank you.
Thank you.